1 million biopsies are done here in the US on men every single year, most of those being random needle biopsies. So the differences between a targeted biopsy and a random needle biopsy, they're taking 12 to 14 cores versus a couple of cores. But since random needle biopsies are kind of the main procedure that's done here in the US, we want to talk about the specifics of how they're done, how accurate are they, and really what your options are. If you're going to go for a targeted biopsy, what's the pros and cons? If you're going to go for a random needle biopsy, what are the pros and cons? So today we're going to go into the specifics of that with Dr. Mark Scholes, who's a 30-year medical oncologist who's focused solely in prostate cancer. Today, Dr. Scholes, we're talking about random needle biopsies. Now, this is kind of a lot of people's introduction to prostate cancer. You know, they get a PSA checked, and then maybe the PSA is elevated, and then typically they're sent for a random needle biopsy. So before we get into the specifics of cores and how all of it works and the reporting of it, what exactly is a random needle biopsy, and why do they call it random?
I think the word random is in contrast to targeted. Before the advent of good imaging, the idea of seeing a spot inside the prostate really was unattainable. We didn't have good enough imaging. Because the gland is small, doctors figured out that with spring-loaded biopsy guns, if they used a grid pattern over the surface of the prostate penetrating into the gland, that they got pretty good coverage. And if they labeled where each of the cores came from, they could map where it was in the prostate and how large the tumor was, judging by how many cores had cancer in it.
When it comes to this process, you know, if men are going to go get a random needle biopsy and they're mapping it out, is there ever the perception that it could miss cancer?
Yes. Precision has been worked out, indicating that random needle biopsies can miss consequential cancers about 20% of the time. Therefore, the policy, for example, in the men on active surveillance of doing periodic follow-up random biopsies, the idea being that with more sticks over time, that you'll discover those 20% of men who had a cancer that was missed on the first biopsy.
If there is a 20% chance that a random needle biopsy could miss significant cancer, and we do have targeted biopsies, but I know targeted biopsies are not available to everyone, and we have an international audience. So really, what do you do in the case that, how would you monitor? Do you have to get another random needle biopsy in 6 months to a year? What are kind of the pros and cons of that situation?
I think that's the usual policy. In fact, that policy still exists here in the United States. Men that have had a favorable random biopsy, maybe it shows grade 6 only, and are embarking upon active surveillance, these men are routinely counseled to get another random biopsy within 6 to 12 months, just to make sure something wasn't lurking in a corner that was missed on the first biopsy. That's pretty much codified, and as I mentioned before, then men who are on active surveillance historically have relied heavily on ongoing random biopsies to make sure that if something new is coming along, that it gets detected in a timely fashion, and that so the ones that need treatment get treatment.
When men get these results, they don't always know what to do with them. You know, they're introduced to the Gleason score and really what that means. But specifically, we've seen a lot of requests in the comment section for explaining what cores positive means and the percentage of cores positive. So let's just deal with, you know, if you have a 14, core random needle biopsy and let's say 7 are positive, what do you do in that situation? What does it mean and how should someone interpret it?
Historically, we've relied upon Gleason score, how high the PSA is, percentage of cores biopsy positive, to project the likelihood of future metastasis. So higher grade tumors, larger tumors, as indirectly concluded by having a lot of cores positive, that means a larger tumor, have a greater predilection for metastasis. And perhaps these individuals are not as good a candidates for active surveillance, or maybe they are candidates for more aggressive treatment up front. If they are looking at undergoing radiation, maybe they should have 6 or 12 or 18 months of hormone therapy because of these factors, the higher grade, greater number of cores, or higher PSA levels. This policy, or this sort of analysis, perhaps is not as critical now that we have PSMA PET scans that are more accurate at actually detecting metastasis. But the backstory, this methodology that's been around for 20 plus years is still relevant in trying to gauge how serious each individual's cancer is and how likely it is to spread.
If you have had a biopsy recently and you need more information about prostate cancer or your particular case, there's a great event happening here in Los Angeles this September. We're having world-renowned experts come in person to answer patients' questions at our Prostate Cancer Patients and Caregivers Conference, and you can learn more at pcri.org. Now, don't forget to click that subscribe button to subscribe to our channel and support us, and if you would like to support us through a donation, you can do that at pcri.org/donate. Now back to my conversation with Dr. Scholes. I'm going to kind of sketch out the Gleason grading system, and please, add anything that I'm missing here. So if someone goes in and a urologist is doing a random needle biopsy, and the Gleason grading system is really based off of 3s, 4s, and 5s. So there's like 3 plus 3, we see 3 plus 4, 4 plus 3, and so on and so forth. So when it comes to cores positive, I've talked to patients where maybe they're in a situation where they're looking at wanting to do active surveillance if they're in a 3 plus 4 category. But the percentage of 4 in those cores is important for their decision-making process. So really, what percentage is significant based off of, let's say, a Gleason for prostate cancer?
This is a continually evolving area because now we do have targeted biopsies as well. So in the era of random biopsies, it was generally felt that you could embark upon active surveillance if you had 3 plus 4. If you had relatively small amounts of 4, that means maybe only 1 or 2 cores with 3 plus 4, and in those cores that the percentage of grade 4 was relatively small. With the advent of targeted biopsies where they are harpooning the mother lode of the cancer, and sometimes multiple times, that same metric is not going to be really representative, because it's kind of like they're doing the same core over and over rather than looking at a spread throughout the gland. Men may be greater candidates who've had targeted biopsies that perhaps manifest somewhat worse Gleason scores, just because, in a sense, they're getting the same biopsy over and over again. It's not multiple cores, where in the random system it's spread out over the prostate and you have multiple cores. That would bespeak of a larger tumor and possibly a less a propitious candidate for having active surveillance.
So when we talk about having percentage cores positive, how much of a difference is it between 5% positive and like 50% positive?
For example, with PSA, the breakdown is like PSA is less than 10, 10 to 20, and 20 and above. So for Gleason scores, we tend to think of 3 plus 4, 4 plus 3, and higher. And for percentages, it's not only the percentage of cores positive. So 12 cores, if half of the cores have cancer in them, that's 50%. It's also, of course, how extensive the disease is within each individual core. But taking the first point, the percentage of total cores positive, it's generally broken down to a third or less, a third to a half, and more than half. So if you're looking at this scalar approach in terms of when are we dealing with bigger and more problematic tumors, PSA is over 20, Gleason scores above 4 plus 3, and more than half of the cores that have cancer in them.
So in the process of getting a biopsy, it's not just getting the tissue samples. You then have them read by a pathologist, and he interprets what he's seeing within these discs, when he sees the tissue samples. So how often are you recommending that men go get a second opinion on a biopsy result and make sure that the percentages of cores positive is accurate, that the grading system is accurate, and really that they're getting an accurate reading on a random needle biopsy?
Pretty frequently, mostly in cases where we're at tipping points. So if people have 5 cores with Gleason 4 plus 4, or if they have half a dozen cores with 3 plus 3. These are the more extreme, and I'm not routinely sending people to get these things double checked. The chances that it will move into a different category is very small. But I almost routinely get double checks from world-class centers of authority in people that have 3 plus 4, and there's what percentage of grade 4 is present, and we're trying to sort of fine-tune these people that are at a tipping point between maybe we can watch it and maybe we have to treat it. So anytime that you're close to possibility that the diagnosis and the treatment would change, I like to get it double checked.
One thing I want to bring to light is we have many people who are getting random needle biopsies and maybe they come back with a Gleason 8 or 9, so we have 4 plus 4 or 4 plus 5 or 5 plus 4, and I really want to encourage patients that just because they get that result doesn't mean that just because they're not a 7 or a 6 doesn't mean that the treatments and the effectiveness of those treatments is not going to be applicable to them just because the cancer is of a more aggressive grade. So can you kind of break down how Gleason 8 works and Gleason 9 in these types of biopsy results and really what patients can expect as far as treatment goes?
These are situations where pretty much universally, unless someone's 85 years old, that you're going to undergo what we call definitive curative treatment. Assuming these men have had a PET scan and there's no metastases, the cure rate should be very high. And it may entail them undergoing definitive radiation therapy, some sort of adjuvant hormonal treatment. The idea of high-grade prostate cancer being somehow universally deadly is really ludicrous. The high-grade prostate cancers in many cases are better than most of the low-grade other types of cancers. The fears that permeate the whole industry because of the way cancer behaves in pancreas cancer and lung cancer and bone cancers and brain cancers, and on and on and on, where these things can be deadly within 6 months, is kind of an inescapable backstory to the whole cancer world, but not at all representative even what localized high-grade prostate cancers are about. These tumors are highly curable, and there's all kinds of fail-safes to handle them even if they relapse. So I don't want to minimize the gravity of the situation, because the treatment for prostate cancer can have an impact on sexual function, and the side effects of hormone treatment are substantial. But the specter of immediate mortality, as you've quoted on the channel before, the 5, 10, and 15-year cancer survival rates of prostate cancer overall in the United States are something like 99, 98, and 96% or 94% at 15 years. There are a small percentage of men that run into trouble over 10 to 15 years and even die, but those are the people that die within 1 to 2 years is almost unheard of, which is unfortunately commonplace with other cancers.
Yeah, and in the situations, because, we will post those types of statistics and we talk about them in our videos, and then somebody will say, well, my uncle died within 2 years. I don't think people are understanding that we're talking about people who are undergoing standard yearly PSA screenings. They're checking it, and they're finding these prostate cancers when they're localized. They're not already in a metastasized state, right. And typically their PSAs are not, over 100 and things like that. So it's a very different situation, and in those cases, we do see the more aggressive timelines when it comes to mortality rates. But in the situations that you're talking about, it's people who are getting PSA testing, and hopefully, they're doing it every year. They're starting early, and then we do see these localized situations. So when it comes to random needle biopsies, a lot of people have great concern over infection, hospitalization, and it can be very uncomfortable. Some men have no problem with it, and other men have a lot. So can you speak to those types of situations, and is there anything to do beforehand to avoid them?
Well, the infection rate has been well documented, and we're talking about infection rates in people who are properly managed. They get antibiotics beforehand, and all the usual precautions. Despite that, there is about a 2% risk of serious infections because you're going through the rectal wall. To me, is one of the main detriments. The discomfort is the other detriment to doing random biopsies now that we have targeted biopsies, and you can get by with maybe 2 to 4 biopsies rather than a dozen or 14, as you cited earlier. So I'm not a believer that random biopsy is truly necessary as of 2024, but we're speaking to it today, of course, because it's very popular, and the information that is gleaned from a random biopsy is useful. I think it can be obtained with a good MRI and or a PET scan and targeted biopsies, but the industry is really not ready for that, and random biopsies continue to be popular. But the downside of them is, as you mentioned, infections, sometimes discomfort. Men can have some temporary impotence as a result. There are men that have developed low-grade ongoing prostatitis that doesn't seem to resolve well. So it's, for the most part, tolerable, but there are exceptions where people have problems.
When we're talking about rare cases, when it comes to hospitalization or infection, is it below 5%, 3%? What is the percentage we're looking at here?
2% with properly performed biopsies. 1 out of 50 men is going to have a roller coaster ride after their biopsy, develop fevers, chills, end up going to the hospital for IV antibiotics. And There's probably people that die from random biopsies every year. These things are not recorded very well. But if we consider that 1 million men have random biopsies every year, 2% would be 20,000 people a year that are developing these septic complications. So there's probably a few of those that develop fatal side effects.
There's a big debate online within patients, and I'm seeing this in forums, I'm seeing this in research papers, I'm seeing this in our comment section, between transrectal and transperineal. And there's a huge focus that transperineal would give you transperineal targeted biopsies. You have a less hospital risk, less risk of infection. So we still see a lot of transrectal being done. A lot of patients are asking for a transperineal biopsy instead. So what are the pros and cons?
Well, the infection rate with transperineal means they don't go through the rectum, they go through the skin, is indisputably lower. It's a little more involved because you're going through a larger area of body to get to the prostate. And so the anesthesia is maybe a little trickier. I think that for people who want to do a random biopsy, for whatever reason, they would be better off doing transperineal biopsies because the infection risk is what concerns me. For targeted biopsies, the incidence of septic complications is much lower. There's a difference between poking through the rectum a dozen times and poking through the rectum 3 or 4 times. I don't advocate that people have transperineal biopsies if they're going to have a targeted biopsy. They certainly can if they want to. There are people that are going through general anesthesia just to have transperineal biopsies, which that entails an anesthesia risk that I think is unnecessary. So transperineal biopsies are a different skill. So you have to check and make sure that the person doing it has had enough experience and that they've developed this ability. The targeted biopsies in particular are important because if you have a targeted biopsy, you're relying on the skill of the doctor doing the biopsy to make sure he actually hits the target. If he misses the target and says everything's fine, that's a very upside down and confusing situation. So bottom line is I think that the transperineal biopsies have a role in people that want to continue to do random biopsies. Since I'm not a fan of using random biopsies, I'm not scouring the country for good transperineal biopsy doctors because the ones that do targeted biopsies transrectally have low infection rates, and those are, of course, more widely available. Bottom line, either approach is perfectly fine if you have experienced doctors that are doing it.
So I've read concerns from patients where they have read that there is a possibility of risk of spread of cancer through a biopsy. And this seems to be a large concern, understandably, if that concept is true. So have you seen this come to fruition? Is this a big risk that we're taking if someone does either a targeted or a random needle biopsy?
I think the short answer is no, and I base that conclusion on some common sense that's available to all of us. About 1 million men undergo random biopsies every year in the United States, and this has been going on for 30 years. We know prostate cancer has a low metastatic potential in general. No one's ever told that they have prostate cancer unless they've undergone a biopsy. And over the years, we're seeing that prostate cancer is characterized by its low metastatic potential compared to other cancers, especially grade 6. The concern that somehow we're changing the natural history of what would have been just because we're poking it with a needle may sound plausible in terms of common sense, but in practical day-to-day experience, the incidence of cancer spread by biopsies must be very, very low.
So if a patient's going to undergo a targeted biopsy and they have these needles going into this specific tumor, how do they make sure that it's accurate and they're hitting the tumor?
Super good question because I think unless you're doing an in-bore biopsy, which is where the patient's in the MRI and they watch the needle go into the lesion itself, you're never going to be 100% sure. One useful piece of information, of course, is to try and match the percentage of involvement in the biopsy core after it's all said and done with the estimated diameter of the lesion that was noted in the MRI. So if they see a 10 millimeter lesion in the MRI and they stick cores in and only 1% of the core has cancer in it, either the lesion's not cancer or they missed the lesion. So it's always comforting in my mind when I match the biopsy results and they say if you have a 20 millimeter core that's removed and 10 millimeters of it is cancer, that would be 50% of the core is cancer. If that 10 millimeter matches what the MRI said was a 10 millimeter lesion, then I'm pretty confident that the guy doing the targeted biopsy hit the target.
What about in situations, I hear about targeted biopsies, and sometimes they'll hit the tumor a couple times and then they'll take some cores around and take like 4 or 5 in order to get some sample tissue around the tumor. Is that something that you want to happen? Is that something that you think is good just to get the compare and contrast to make sure they didn't miss it?
I think that's important for people who are hopeful to undergo focal treatment. The idea of focal treatment is that you want to get it all, but you don't want to treat more of the prostate than you need to hopefully minimize the risk of impotence and incontinence and other problems. Cores around the visible lesion are, out of respect for the fact that MRIs are potentially going to underestimate the size of the spot and that there can be cancer outside what was visible, usually right in the same environs of the lesion. So I think that's a savvy thing for patients who are on a track towards some sort of focal treatment. If you're going to have your whole prostate treated anyway, I think you just need a diagnosis because they're going to basically carpet bomb the whole prostate. The extent of the tumor is not really that relevant. In the old days, it was relevant as part of the paradigm to try and predict the likelihood of future metastasis, which, as I said before, I think has been diffused a little bit by the advent of these new PSMA PET scans.
A lot of times I see, and this is kind of frustrating, especially in active surveillance patients, you'll have a patient who is requesting a targeted biopsy, and then you'll see that they get a random needle biopsy on top of it. We see this in active surveillance clinical trials. We see this internationally with patients who are requesting targeted biopsies, and they're having to go under, multiple cores, not just the targeted now, not just the, 12 to 14 needles, but it's getting up there. So why do we see this, and is there any way to avoid it?
Well, let's deal with avoiding it. I think the communication with the doctor doing the biopsy, this doctor should be selected for their ability to do targeted biopsies. I think one reason that the random biopsy is done is that maybe the doctor is not that confident in their targeted biopsy skills, and so they're kind of covering the waterfront by doing a random biopsy just to be safe. But communication with the doctor doing the biopsy and stipulating specifically that I don't want the random biopsy, because they're not advertising up front when you set up a targeted biopsy that they're planning to do a random biopsy as well. Random biopsies have been the policy for so long, many of the doctors don't even see the need to even mention it. That accurate communication up front, and you know that things have gone wrong if people are taking more than, say, 4 to 6 biopsies, and the biopsy experience just goes on and on and on. I don't recommend this necessarily, but I've had a patient who actually got up off the table and because he had clearly asked for a targeted biopsy, and communication was lost, and they ended up doing a random biopsy as well, and he did not want that. Certainly important that the doctor doing the targeted biopsy has the skills to do it properly, but in that context, just doing an additional random biopsy is something that often will get thrown in without even being mentioned if the client specifically is looking to just have an isolated targeted biopsy. They need to really stipulate that clearly, because it can get lost in translation very easily.
I mean, for a patient to get up in the middle of a biopsy, that's quite a monumental moment. Now, you said you've had a patient. This wasn't your patient, and you obviously weren't doing the biopsy, correct?
It was my patient, but another physician was doing the biopsy. So we have patients all over the country, and we look for local places where they can get biopsies. I am pretty impressed by that patient's commitment to forego the random biopsy, but I understand it. These are uncomfortable, and there are repercussions, potential serious repercussions from random biopsies.
I still see saturation biopsies happening, and mostly in international countries, and not so much here in the US, but a lot of times they'll say, well, we want to make sure we don't miss the cancer, so we're going to go take 30 to 40 cores out of your prostate, and it's very intense. So if somebody doesn't want a saturated biopsy, but they don't have access to a targeted biopsy, would it make more sense to have a random needle biopsy and then get it repeated maybe in a year or so if there is concern in that 20% that they are missing the cancer?
I would agree with that, although I'm not a fan of random biopsies either. I am even less a fan of saturation biopsies. You can see on paper why it's attractive. If there's a 20% chance that you're missing something on a random biopsy, if you did 2 or 3 times the number of cores, that risk of missing something is going to go way down. Typically done under general anesthesia as well, which has some risks that are unnecessary. Yeah, I understand the underlying rationale for it, but the premise that prostate cancer is so dangerous that we need to find every tiny little bit is clearly not supported by our experience or any of the literature. Thankfully, in general, prostate cancer tends to be a forgiving condition that allows you to watch it over time. And should something develop later on, in almost all cases, you're going to catch it still at a curable stage.
And for a lot of these men that are in this situation and they're getting, these biopsies and they're maybe new to prostate cancer, they're new to PSA screening, and they're in this situation, I think it's good to note that a lot of these men, 50% of them are going to be Gleason 6 patients where they have a type of prostate cancer, Gleason 6, where it'll never metastasize. So if you have all these people being diagnosed here in the US with prostate cancer, 50% of those people are Gleason 6. And I wish that people knew that ahead of time before they went in and got a biopsy, because then they get these results, and a lot of times people with Gleason 6, based off these biopsy results, are pushed to surgery or radiation or more aggressive treatments. And so I think it's just a good thing to put into context if they're in this situation to watch out for that ahead of time so that they don't get pushed into something that's not necessary.
I totally agree.
If you are about to have a biopsy or you have just had one, I would encourage you on a couple of things. Number one, prostate cancer is slow growing even in advanced cases, so you have time to research what your options are and know ahead of time what is the process of getting the treatment, what are the side effects of that treatment, and what is the post-care of that treatment. The other things to think about is quality of life. What does your quality of life look like? Even though you've been diagnosed with possible cancer, you want to make sure that you're thinking about what your priorities are. If you want to preserve your sexual health or your urinary health as much as possible, what are your options? And the other thing you want to think about is building your own medical team. You want to get second opinions. You want to interview experts in the possibility that maybe they've done a couple hundred of the procedures you may be thinking of, or maybe they can give you more information, somebody you feel comfortable with. And you want to make sure that they are answering your questions. There are two factors in prostate cancer that I see oftentimes in men specifically go silent. And one of those things is that they don't speak up about their mental health and they don't speak up about your emotional health. And so I think it's very important to bring someone alongside of you that you trust that can go through this process with you. Maybe it's your partner, maybe it's your friend, maybe call our prostate cancer helpline because they're prostate cancer patients who have been through this, and they're designed for people who don't have someone to support them. They have a wealth of information and you can learn more about them and reach out to them at pcri.org/helpline. But your mental and emotional health through this whole process, even talking out your anxieties, is very important. Talking about what your priorities are in your quality of life is important. There are a lot of treatments for prostate cancer, and you want to make sure that you know your specific case and that you're comfortable with the treatment that you're getting, and that you know ahead of time what the pros and cons are and what to expect. Too many times I see prostate cancer patients go into a treatment and they don't know what to expect, and then they deal with side effects that oftentimes can be lifelong, and they feel like they should have known ahead of time. But in reality, there's a lot that can be known ahead of time thanks to research, and you can do your research with us through the helpline, through other advocacy groups and support groups, which I will list in the comment section below this video. But please reach out. Please speak up for yourself. You're important. We care about you. And I don't want you to be alone through this process. I know the whole process of even getting a biopsy and getting, the idea that you're having cores taken out of your prostate, you're going under something to do that, maybe you're under anesthesia, and then on top of it, you could be diagnosed with something. That can cause a lot of anxiety. That's a lot of stress. So please take care of yourself. You want to think about the whole body of what you're going through and make sure you're talking it out, you're speaking up about your concerns, and you're valuing yourself through this process. It's not just about fighting cancer. We want you to go through prostate cancer, the experience of a diagnosis and choosing a treatment with as much care as possible. And there's a lot of resources out here in the prostate cancer world for you. And again, I will list them below in the comment section. Please don't be shy. Please click on them. Please reach out to the help, people and the help that you need and for the help you need. We appreciate you, and we want you to know that you're not alone. Subscribe to this YouTube channel because we come out with new prostate cancer videos every single week, and I appreciate you watching this video. Please reach out.